Welcome to The Explainer, where we break down complex topics into clear, concise presentations.
So, this explainer is a real deep dive into Actinomyces oris, and it's specifically for those of you in the clinical lab. Just so you know, all this info comes from a Gemini deep search, and you can check out the full sources in the linked notebook. The images, by the way, are from Microbe Canvas. Okay, let's jump right in.
So, here's our game plan for today. We'll start with how this species got redefined, then we'll tackle the challenge of actually identifying it. After that, we'll get into the key clinical syndromes, talk about antimicrobial management, and wrap things up with infection prevention and control.
All right, first up, a species redefined. And look, this is way more than just some dusty old taxonomic shift. Why? Because this reclassification back in 2009 has direct, real-world clinical implications.
So, check this out. Before 2009, Actinomyces oris was basically hiding in plain sight. We just knew it as Actinomyces naeslundii genospecies 2, and our routine methods couldn't tell them apart. Then in 2009, researchers used multi-locus sequence analysis, or MLSA, on housekeeping genes, and boom, that gave us the clarity we needed. After that, Actinomyces oris was officially recognized as its own distinct species, and it turns out it's the most abundant one of that old group found in our mouths.
Okay, Section 2, the identification challenge. So you can see how that little taxonomic twist creates a big puzzle for us in the lab, right? Identifying this bug is a real journey, from the microscope all the way to the mass spectrometer. Let's start with the gram stain. I mean, this thing is a real shapeshifter. It's a gram-positive pleomorphic rod, but it can look like a diphtheroid or show these branched filaments or even look coccobacillary. But we have a couple of quick tricks up our sleeve. A key differentiator is that it's non-acid fast, so that helps us rule out nocardia. And it's spot indole negative, which is great for telling it apart from Cutibacterium acnes. Now, what about on the plate? This is where you can see a really telling difference. Actinomyces oris usually grows these smooth, convex, white or cream-colored colonies. It's what we call the S form. And that's a huge contrast to Actinomyces israeli, which is famous for that rough, sticky, molar tooth look. They both pop up in about 48 to 72 hours, though sometimes Actinomyces israeli can take a bit longer.
Okay, let's talk biochem. The single most useful test here is probably the catalase test. Now, it's not foolproof. Nothing ever is, right? But about 70% of Actinomyces oris are catalase positive. And since Actinomyces israeli is always negative, a positive result really points you in the right direction. It's a simple but really helpful clue.
So this is where we get into the modern-day solution. If you try to use 16S rRNA sequencing, you're going to have a bad time. It's just unreliable. Because the homology between Actinomyces oris, Actinomyces nelandii, and Actinomyces johnsoni is over 99%. The real gold standard? You got to use housekeeping gene sequencing, or even better and faster, MALDI-TOF MS. But, and this is a big but, you have to make sure your MALDI-TOF libraries are updated. If they are, you'll get a reliable, definitive ID.
Okay, part 3, key clinical syndromes. Now that we know how to nail the identification, let's talk about why it matters. We need to know where this opportunistic pathogen actually causes disease.
So when you think Actinomyces, you probably think lumpy jaw, right? And for good reason. Cervicofacial actinomycosis is the most common form, making up about 50 to 60% of cases. You get this slow-growing, hard, almost wooden-feeling mass with draining sinus tracts. But it's also tied to things like root caries, and it's frequently found in MRONJ, medication-related osteonecrosis of the jaw. And while it's rare, it can cause serious systemic infections. We're talking bacteremia, endocarditis, and even infections on devices like IUDs.
Now here is a massive diagnostic clue: sulfur granules. These are yellowish, macroscopic particles you can actually see in the exudate. Fun fact, they're not made of elemental sulfur. They're just tangled masses of the bacteria. Finding these is a huge hallmark of actinomycosis. It's one of those things you should definitely tell clinicians to look for.
All right, let's get to the really practical stuff. Section 4, antimicrobial management. This is all about navigating its intrinsic resistance and the current treatment guidelines.
Okay, everyone, listen up, because this is absolutely critical. Actinomyces oris is intrinsically resistant to metronidazole. This is a huge clinical pitfall. Why? Because it lacks the enzyme needed to even activate the drug. So if you're treating a suspected anaerobic infection with metronidazole alone, and this bug is the culprit, it's just not going to work. It's also resistant to aminoglycosides and cotrimoxol and has high rates of resistance to fluoroquinolones. This is need-to-know stuff.
So when it comes to susceptibility testing, what's the standard? Well, right now we don't have species-specific breakpoints for Actinomyces oris, so we rely on the EUCAST breakpoints for gram-positive anaerobes. As you can see, benzopenicillin is a great option with a susceptible breakpoint of less than or equal to 0.25 milligrams per liter. Meropenem and clindamycin are also on the table.
Let's look at how we actually treat this. If you compare the Dutch guidelines to other international ones, the initial phase is pretty much the same. High-dose IV benzopenicillin for 2 to 6 weeks. Where they differ is the total duration. International guidelines have traditionally recommended these really long courses, like 6 to 12 months. But the Dutch guidelines suggest that if you have good surgical debridement, 3 months is often enough. It's a trend towards shorter courses, but it all hinges on good source control.
And what about for kids? It's rare, but when it happens, you have to be aggressive. The maximum recommended daily dose for amoxicillin, especially for severe deep tissue infections, can go all the way up to 100 milligrams per kilogram per day. That's a serious dose, but it's what you need to get the job done.
Finally, let's touch on infection prevention and control. This part's pretty straightforward because we're dealing with an endogenous threat.
So the key thing to remember is that you don't catch this from someone else. Infection is endogenous, meaning it comes from a person's own bacteria. Because of that, in the hospital, standard precautions are all you need. In the lab, though, it's a different story. It's a risk group 2 organism, which means you have to handle it under biosafety level 2 or BSL2 conditions.
Okay, so let's boil it all down. What are the 3 things you absolutely have to remember? Step 1. Think beyond 16S. Use MALDI-TOF or housekeeping gene sequencing to tell Actinomyces oris apart from its relatives. Step 2. Remember the resistance. Actinomyces oris is intrinsically resistant to metronidazole. Do not use it as monotherapy. And step 3. High dose, long duration. Treatment means high doses of penicillin or amoxicillin, but remember, you can shorten that duration with excellent surgery.
And that brings us to our final big question. How can we, in the lab, do a better job of communicating all these clinical implications to the clinicians? I mean, how do we make sure that when they see Actinomyces oris on a report, they immediately think, no metronidazole?
I'm really curious to hear your thoughts on that. How do you handle this in your lab? Drop your ideas and feedback in the comments below. And hey, if you enjoyed this explainer, please subscribe to the channel for more. Thanks for joining us today.